Good afternoon, ladies and gentlemen. Masakum Allah bil khair. Welcome to this session, which will be a live transmission from Mubarak Alkabeer Hospital in Kuwait. I'm honored to have, actually Dr. Hussam Noor was supposed to be chairing this session, but he was called for an emergency. So I'm chairing in his place. I hope I can do as good a job as he is. He's an excellent guy. And we have with us Dr. Adel Atribi, Dr. Carlo Di Mario, Dr. Jassim Al-Hashimi, and Dr. Abdullah Ismail. Dr. Abdullah is a consultant interventional cardiologist from Mubarak, and he'll be helping us with the factoid slides. I know you're familiar with all the panelists, so we're not going to go through that. And perhaps I should start by congratulating Dr. Fawaz Al-Mutairi for this successful meeting, he and his colleagues, Dr. Musa and others. So congratulations for a job well done. A meeting that has a society that was established 5 years ago and has taken off in an honorable and proud manner. Without much ado, are we ready for the live transmission? Okay, so nice video. Good afternoon, Dr. Ali and Dr. Fahad. So we have with us, I'll just do a brief introduction. Dr. Ali, an interventional cardiologist, and Dr. Fahad is also interventional cardiologist, both trained in US with a taste of Canada, and they've been back in Kuwait for 2 years. And since then, they've been doing all the good work that happens in any cath lab. So tell us about what you have today. We have the panelists here, Dr. Adel Atribi, Dr. Carlo Di Mario, Dr. Jassim Al-Hashimi, and Dr. Abdullah Ismail. So we'll give you the podium, Dikatra.
Hello, everybody. So I'd like to first thank the GIS organizers to give us this opportunity to present this live case, the first one in Mubarak Hospital. So let me introduce myself. I'm Dr. Ali Al-Sulaimi. Next to me is Dr. Fahad Al-Hajri. We have our nursing assistant, Mr. Sam. At the head of the table, we have Mr. Dilip, who is our X-ray technician. We have Mr. Binish, one of our nurses, and Dr. Mamdouh, one of our cardiology registrars, and Ms. Swani, also one of our nurses. So without further ado, I'll let Dr. Fahad present the very interesting case for us.
Thank you, Dr. Zvaid. I would like to thank the GIS. What you guys have done in the last 5 years during the pandemic is really something you should be proud of, and we all should be proud of in the region. And thank you for allowing us to do our first live case transmission from Mubarak Hospital. So if we can go ahead and present the patient, please. Can we have the PowerPoint? All right, so our patient is next, please. Our patient is a 58 years old gentleman who's known to have diabetes, hypertension, and hyperlipidemia. Back, please. Go back, please, on the slide. He's also known to have coronary artery disease, one more back, who had a STEMI in 2010 in India or in Sri Lanka in July. At that time, he had 2 DES to the OM2 with a CTO of the RCA. Later, just 4 months later, they attempted to open the CTO RCA, but they failed. Next. In July this year, just 4 months back, he was in Sri Lanka and he had an anterior STEMI. He was given TNK. His coronary angiogram by report showed a normal left main, heavily calcified LAD, and heavily calcified LCX with 90% stenosis. He had a patent stent in the OM2. The RCA is still CTO. So he was offered CABG, but the patient declined. PCI as an option was not given to him. He completely was against the CABG. So he was fine for 3 months. Next, please. He came back to Kuwait, and just last week, he presented to us with end STEMI. He had typical chest pain. His exam was not impressive. Beside basal cracos, he was hemodynamically stable. His troponin was mildly elevated, was at 170, and this is a high sensitivity troponin. Creatinine and other labs were unremarkable. His echocardiogram showed an EF of 20 to 25% with hypokinesis in the basal inferior posterior wall. And his right was fine, no significant valvular disease. Next, please. This is his ECG, nothing impressive. Sinus besides some T-wave inversion in 1 AVL and lateral leads. Keep it for a second for you guys to take a look. And let's go to video 1, please, next. So this is his coronary angiogram that was done a few days back. I will leave it for guys to absorb it, kind of. So he had a patent stent in the OM. He had a diseased circ. Next. His LAD is heavily calcified and stenotic. Next. This is the RCA CTO from 2010 and failed attempt at that time. Next. And this is his LV gram. Next. All right, so in summary, we have a 58 years old gentleman with an EF of 20 to 25%. He, go back please, he had an anterior STEMI just a couple months back. He declined, go back please, declined CABG. And he came into us with the angiogram that you just saw. His STS score is 9.1. We offered CABG again. He's still saying, I would rather die instead of doing the CABG. So he's absolutely against the CABG. Next. So what will be your approach, guys? You can play the video. I will leave it for the panel, Dr. Zvaid, to discuss what's the approach.
So
you can show them the video, please. Video 1.
We'll ask our panelists, Dr. Adil or Dr.
Well, this is a very complex case because it it has extensive coronary artery disease, heavy calcification, even some bends in the proximal LAD. I think even because the patient declined surgery, but surgery was not really a good option because of the diffuse distal LAD disease. Actually, the LAD is not that good distally. I think with this kind of ejection fraction, maybe you can use some support with maybe Impella, intra-aortic balloon or something. And of course, imaging here is a must because of the heavy calcification. And then you decide by the imaging whether to do IVL or ROTA or whatever, but I will start usually with the LAD first.
Carlo?
Well, first of all, let me congratulate the colleagues for taking such a complex case. You know, the young life of a 56-year-old man is at stake here. 20-25% ejection fraction. He had a big damage to the anterior wall recently because of old-fashioned thrombolysis that still open the LAD, but you see which condition the vessel is, and he had this occluded artery, the right coronary artery, was a failed attempt of recanalization. You may imagine that if this was successful, we could see here a very different situation in terms of myocardial damage. And of course, eventually you will need viability to check that territory as well. But here we are dealing with the left coronary system, of course, the LAD first, and the mid left circumflex, which has a more focal, relatively easy to treat, appears lesion. I couldn't see calcium, at least in the circ, while there is a rail of calcium from the distal left main ostial LAD to the mid LAD and some diffuse distal disease. I confess I could see on the table already a rotablator, so I try to agree with the choice of the colleagues. When you have such a long disease, you need, if you use lithotripsy, multiple balloons, but also you have a chance that the balloon doesn't go and you need predilatation and so forth. Okay. So I think the issue is to have a device that used carefully can make your way then for using, if needed, lithotripsy or high pressure balloon, stent implantation. I will try to stay provisional on the left main after having done well, here the mid LAD, the mid circ doesn't look so severe, but we will see better. The last question is protection in terms of hemodynamic protection or not, and I see the answer already. With such a poor left ventricular ejection fraction, the need of using a technique that has a chance of inducing showering of small particles of calcium like rotational atherectomy, especially if you treat very long segment, that's a must. And they have chosen the right one, which is Impella.
Perfect. Dr. Jassim, any comments?
No, but just my comment on the left main, proximal left main, because there is partly some haziness there. So are we happy that we have full information about this coronary, or maybe we missed something there hidden which not seen here?
We can ask Dr. Ali. So Dr. Ali and Dr. Fad, what's your plan? What are you going to show us?
Okay, we're going to discuss the approach for this case. Can you show us the next slide, please? The slide, yeah. So our approach is we're going to go with mechanical support with the Impella CP, the new one, the Smart Assist. And we're going to use the left femoral access for the Impella. The next thing is we decided to go with the right radial access with a 7 French guide catheter. And our plan is to do extensive plaque preparation for this case. So we're going to go up front with a rotablator, 1.5 millimeter burr. We may upset to 1.75 if needed. And then we're going to do balloon predilatation sized 1-to-1 with the vessel, with a non-compliant balloon. And then we will consider maybe a further atherectomy, further preparation of the plaque with either a cutting balloon or high pressure balloons, or shockwave balloons, sorry. After we prepare the lesion, we're going to do OCT imaging, okay, with the Abbott OCT, the new software. This will help us to see if we need additional preparation, whether we've actually prepared the lesion, fractured the calcium. and also help us with sizing the stent and decide where the landing zone will be for the stents. After that, we'll do our final post-dilatations and final OCT evaluation.
Okay, well, show us how you're going to do that. Wish you good
All right.
luck.
All right, thank you. So we're going to get started. We can talk in the middle. Just the first question for this case, obviously, whether we should use support or not. I'm not going to go into the evidence behind this because this is going to take us nowhere after like 2 hours of discussion. But the bottom line for our decision for this patient, he is complex multi-vessel disease. That's one. Two, his EF is low, 20 to 25%. And then number three, that he has recent NSTEMI and STEMI. So the risk of having no reflow is very high in this case. And that's why we're gonna take all the measurements, especially he's a young patient. So we're not gonna take any risk doing, a trial of not doing a mechanical support. We're gonna maximize everything we can do to help this patient out. As you can see, we're advancing the rotor pro now on the dyne glide. That can be done with a single operator technique. I'm just helping Dr. Ali here. So that's the burr is just in the left main now. I don't know if you, we have a camera down there that we can, yeah, dyne glide is off. Most importantly is you take the brake defeater off so you can start your rotor. All right, we're gonna have our first run now, live.
5 seconds. 10 seconds. 15 seconds.
Okay.
So the ideal for the rotor, just more especially with this patient, is we're gonna go with 15-second run, and in the middle, kind of, a 30-second break to give the vessel, time to perfuse and see the hemodynamics for the patient. This is a tortuous vessel to start with, so we're gonna give it time and take it slowly.
Looks fine.
I was worried about this kink, but the LAD, the osteo.
Maybe, Abdullah, you want to show something on the use of impella in this situation?
Sure.
We've heard about mechanical support in cardiogenic shock, but this is a different
Sure.
scenario.
Can you show me the slides, please?
5 seconds.
What was the bear?
10 seconds.
Slides.
It was 1.5, I think. 5, yeah, it's a bit big, no?
15 seconds.
In our center, we don't have impella, so we are using sometimes ECMO in these difficult situations after right side study, so that to see the right side pressure. Can you elaborate on this, Abdullah? On the use of ECMO if you don't have an impella and you have to do a right side catheter, what?
Sure. We just, because you have some slides about like support with impella, and then we'll speak about ECMO.
Dr. Ali, I guess I can ask you if your burrs don't go through, and what's the next plan?
5 seconds.
So we're going to do several runs of rotor here. We're going to have to be slow because we can see that this pressure is dropping when we are ablating the calcium. So hopefully, we hope that the rotor burr will be able to cross those lesions. And if that was successful, then we'll pre-dilate 1-to-1 with an NC balloon. If that doesn't work, then we have the option of shockwave or cutting balloon.
You were asking if the rotablator burr doesn't cross, isn't it? Well, it's hardly ever the case. Honestly, you just increase your speed, and when you go above 200,000 rotations, it will go 99% of the time. Hardly ever you have to downgrade a 1.5 to 1.25. I think that's the way to go.
No, he crossed.
15 seconds.
Getting somewhere.
They crossed.
They crossed.
Okay, so if you saw that, I'm going to store it. You can see that the rotator actually crossed the proximal lesion. So that's a good sign. We managed to ablate that area pretty nicely.
How is the patient's hemodynamics, Fahad? Yani
I
blood
mean,
pressure?
obviously, yeah, the blood pressure is a little bit get affected with the rotor. So whenever we're doing it, his blood pressure is dropping a little bit. His MAP is 67 now, so we're fine.
And what was his LVEDP, or I don't know if you did
You know, we did
wedge
actually.
pressure?
We started with the right heart cath. We are good, Dr. Zbey, that you asked. His weight is not bad. It was like 16, 15, 16. His RA was actually on the lower side. So we are fine in that regard. So he's not overloaded. But we diuresed him pretty well before the procedure. So if anything, he may need volume.
Okay, we have the slides ready.
Sure.
So mechanical circulatory support in high-risk PCI. We have only one randomized controlled trial looking at this question. It's the PROTECT 2 trial. PROTECT 2 trial, which randomized patient with high-risk patient that's unprotected left main with low EF or multi-vessel disease with low EF to either get revascularization with Impella, 2.5 Impella, this is the old generation Impella, versus intra-aortic balloon pump. This trial was a negative trial looking at 30 days major adverse events. However, if we look at 90 days, as per protocol analysis, it has statistically significant reduction in major adverse events. So we learned a few things from the PROTECT 2 trial. One thing is that complete revascularization is important. And second, there is also some technical skills that has learning curve with the Impella and providing more support. Then we move on to the PROTECT 3 trial. So PROTECT 3 is not a randomized trial. It's a prospective study, which they looked at patients with the PROTECT 2-like patients, so same inclusion criteria of PROTECT 2 patients. And they compared them to the PROTECT 2 result. So in the PROTECT 3 patient, we have patients with lower EF, more 3-vessel disease compared to PROTECT 2 patients, more severe calcification, longer lesions, more number of vessels treated, more atherectomy use, more left main treated, and definitely longer support, which resulted in more improvement in the STS, that means, in the syntax score, sorry, that means more revascularization. And the result was, at 90 days, there was significant reduction in MACE, 15% in the PROTECT 3 patients and 21% in the PROTECT 2 patients. And also less bleeding complications compared to the PROTECT 2 patients.
Perfect. If anybody from the audience have any questions or comments, they're welcome to come forward.
So I have a question.
So Ali, Fahad, where are we now? What have you achieved so far?
So we were able to cross the lesion. We did one abolishing one. Now we have two options. One of the options is to do a microcatheter and then exchange for a workhorse wire. But we thought this lesion is pretty, well done. So we're just going to do a wiring with our workhorse wire. Now we're going to do NC with a 3.0 NC balloon and before imaging, actually.
Doctor, once the patient is getting a STEMI and with this LAD lesion, would you prefer to do viability or just go?
So we thought about that. If you saw the LV angiogram, there's clearly movement in the anterior wall, and we thought
Fix
that
my,
was
earpiece.
that was enough. And the patient was admitted with symptoms of angina. So we did not do viability per se.
So how long we can do rota after STEMI? Should wait 1 month, 2 months, 3 months?
Go, 20.
I'm sorry,
If the patient got
So
STEMI,
this is,
when we can go and
his
do rota?
STEMI is old. The STEMI was 2000.
I mean, how old we
no,
can
it was
wait?
4 months back.
Was 4 months back.
4 months.
Yes, yes.
His STEMI was 4 months back. But looking at the LV angiogram, we thought there's enough viability, and we didn't do we didn't do any viability studies. I don't know if the panelists agree with that, or would you have done viability studies?
Well, there is a debate about viability. I mean, and when there is LAD involvement, I don't think viability will really matter, because correcting the LAD will definitely help the patient, whatever his ejection fraction. But my belief is that Pella will give you more satisfaction, but no real outcome that we can see.
Well, yeah, well, I agree that like the randomized data didn't support the use of Impella. If you're looking at intention to treat at 30 days, it was a negative trial. That's the only trial that we have, the PROTECT 2. The PROTECT 3 is a prospective trial, so maybe the data is not as strong as we want it to be, but this is the best available evidence
We'll do this first.
in terms of mechanical support in high-risk patients, not in cardiogenic shock.
Makes you feel better when you're dealing with
I
the
think
only...
it makes you feel better, and also, like, if you want peace, you have to prepare for war. I think we want peace in this case.
But there is a randomized trial going on, PROTECT 4, really large
But
number
still,
of patients.
yeah.
Of course, we don't have
We
the
don't have the
results.
result yet.
I mean, I'm in the DSMB, and there are lots of events. They are very complicated patients. I'm sure we will get the answer.
Absolutely.
Perfect. What balloons are you? Sorry, what balloons are you using?
So now we're doing NC30 at 20 atmosphere. This is 15 NC balloon, and now we're at 20 atmosphere or 22. I think we need more contrast on the balloon.
Did the balloon rupture or?
In the first
We
one.
ruptured the first. This is the second.
When do you plan to do imaging? At
We're
this
gonna
stage?
do it next.
We'll do it next. Okay. So now we're going to do the imaging.
Now we're gonna use the Abbott new software that we have for the OCT. The question now whether we should, use IVUS or OCT. I think, calcification is better visualized with OCT. For this patient, we are protected with, his creatinine is normal, so I think OCT is better for this patient. We were able to pass the balloon. We should have a good opacification, hopefully. So OCT should be good for this patient.
We have a good experience with OPN balloon, high pressure balloon, and it really gives a good result, a good preparation of region, especially in calcified. And the risk of rupture is much less than regular non-compliant balloons.
Samson,
Anyone
take
has
care of
more
me.
experience with that?
I think, Abdullah, you have something on
Yes.
on that you want to show.
In terms of the calcification?
Yes.
Sure. Okay. So the slide is small there, but maybe if we can. So usage of intravascular imaging, either IVUS or OCT, and the quantification of calcium. Like if you have any patient with moderate to severe calcium, I think you should always start with imaging, and then you can use the scoring system to predict which patient will have an underexpanded stent, and thereby using calcium modification. So for OCT, like if you have an arc of calcium between 180 to 270, it's a severity score out of 5. So if you have an arc of calcium in OCT between 180 to 270, you're going to get 2 points. If it's more than 270, it's 3 points. And then you look at calcium length of more than 5 millimeter and calcium thickness more than 0.5 millimeter. Each one of these will take 1 point. So if your score is more than 3, you're severe and you should use calcium modification. The same criteria, like more or less, applies to IVIS. So if it's 180 to 270 is 2 points, more than 273 points, length more than 5 millimeter, 1 point, and you add 1 point if you have the length and the arc more than 270. In IVIS, you cannot really assess the calcium thickness, so they modify the criteria for IVIS.
3.5.
But anything more than 3, you should use a calcium modification.
Perfect.
So as you can see, we've attempted to pass the OCT. It did not cross. So we're going to do another balloon with a 3.5 NC.
So if the balloon crossed initially, why don't we go for IVL, Dr. Sulemi?
We can. We're going to try with the 3.5 first. If that doesn't work, then we can use cutting balloon or IVL.
Cannot hear.
Or we can upsize even the Alkabeer to a 175.
You may have a point if the high pressure balloon inflated just to spare material and reduce cost going with a simple high pressure balloon extending. Of course, IVL may have a possibility to improve the outcome, but you don't always need it after rotational atherectomy.
So you see here the 3.5 NC nicely expanded.
Does the balloon cross easily, or?
Yes, yes. At this time, yes.
Why don't you IVIS? No, there's
Could
no.
be the profile of the OCT catheter.
We'll try it again. If it doesn't work, we may consider IVIS. Because even the IVIS is, bulky. Come down.
Carlo, how does imaging change your mind as to how to deal with this? Now you've already got your birth through. How does imaging, OCT or IVIS, add to your decision making?
Yeah, well, I mean, this is in a way is poor man eye was looking at the balloon inflating, especially if you're doing 2 views, that already gives you an impression. Intravascular ultrasound or OCT will tell you whether there is a fracture that I think if you use high pressure balloons or atherectomy system makes a difference, maybe not for IVL. For IVL, you may have microfracture that you don't see. But I think for the other system, there are good papers from Japan showing that predict the expansion of the stent later on. In this particular case, I think part of the answer is about the left main, which I initially thought was involved, and in fact, in one of the views doesn't look like. I think you want to be 100% sure that you can just do a stenting flush from the ostium without having a big plaque hanging into the bifurcation left main.
Yes. At least angiographically doesn't look extending into the left main.
I just gave some nights where there was some sluggish flow. Hemodynamically, it's good. So.
Our blood pressure is really good.
Ali, I think, Ali, with the mask you're wearing,
We can't hear you.
you always wear this mask. Your voice is a bit muffled.
Yeah, sorry. So what I said was that there was some sluggish flow when we puffed, and we had to give some nitro. So I just wanted to let you guys know that that's what we did. So we're going with the OCT again, see if it goes through.
Can I ask a question to them? So, Dr. Al-Hajri, what you are looking in the OCT, more information than IVIS will tell you here.
Obviously. So, we know the calcification is better visualized with the OCT. Sometimes if you have a very bright calcium, you cannot assess the depth of the calcium from the IVIS. As Dr. Abdullah mentioned, the criteria for, a preparation before any plaque modification. I think for this patient, we're going to see the result next. Whether you have an arc of more than 180 or 270, it's make a difference. What is the thickness of the calcium? And then what's the length of the calcification? For this, it's going to be a long, no question about that. But we're going to assess the thickness and the arch or the angle of the calcification. IVUS is good if you have someone with renal failure, if you cannot, if you have something ostial or left main, no question IVUS is a good alternative. But I think for this patient, OCT is the way to go if we have a good flow, and luckily I think we have a good flow here.
Yeah.
This is, we did a co-registration, so we're gonna assist that with the co-registration shortly, we're gonna show you.
This is the new software, so there's a lot of nice things about it.
Can you show us OCT media, guys, please? Yes, so you're on OCT or live.
So the new software, if someone is not familiar, it starts proximally and distal. So the left is proximal, the distal is on the right. It's reversed from the previous. And I'm starting distally here. So this is the very distal LAD. There's a lot of plaque, a lot of calcium, as you can see. Here is also diffusely diseased, but not very stenotic. Okay. So I'm going more proximal as I'm moving.
As you can see, it tells you the thickness and the angle of the calcification.
So here you can see some plaque modification. You can see like a dissection. Can you hear me well? Or?
The voice is a little bit muffled, so we really...
Yeah, maybe it's the mic. Maybe it's the mic.
So you can see there is a plaque modification. I think we cracked the calcium here. If you stop, Dr. Ali, on one of the angle, like it shows, like, this is like, it tells you that there is like a 219 degree of calcification on the top right. You see it on orange there. And the thickness is 0.92. So this, I think, based on the score that we had 1 for the thickness of more than 0.5. We have 1 for the length of more than 5 millimeter, and then we have an angle of more than 180. So that will give you at least 4 points on the score. This is mandating us to do some plaque modification in different ways, and that's why we went up front with rotablation.
Oh, this is the left main now. So, and this is it. So we're gonna see where we can land the stent. We're gonna go to sizing.
So in the sizing, you can see the middle screen where the cursor is moving. Right and left is proximal and distal. So what we need to do on the right, we need to land the distal reference, and then on the top, on the far left, you want to do the proximal segment. And then in between, this is your length. So this is what Dr. Ali is trying to do, and it's good that he can have a control, the main operator. I don't know if you guys see us here, he's doing it and sterile, so this is pretty good.
Okay. So I've done some, I've done the length here. It's we're gonna land in a kind of a mixed zone where there's some calcium. But that's okay because it's hard plaque, it will not cause dissection, edge dissection. I mean, we can't treat this entire LAD, it's all diffusely diseased.
This is your point there?
Yeah, so this is, I mean, I think if the panel also wants to comment on this OCT, if they want me to go in a certain point, they want to review, this is your chance.
Do you want to co-registration and you already did standing?
Yeah.
Can we see the co-registration?
Can you hear me there?
Yeah.
Yes.
Dr. Al-Hajri, it seems there is still a big burden of calcium around the proximal and mid LAD. So, are you happy about the result?
Correct.
It's really, still, you have a lot of calcium remaining back. And the lumen is not that much tight.
Again, in the back, like a few years back, we thought the idea of the atherectomy is debulking. We're not doing debulking anymore. What we're doing now is a plaque modification. The idea is just to crack the calcium and have a better NC balloon expansion, and that's what we aim for, and that's what we got. There is no way we're going to ablate all this calcium as long as we have a crack, a good expansion in the NC, and that's our goal. And that's why, we have less and less no reflow since we've changed our practice from debulking the vessel into just a plaque modification.
I fully
The other
agree.
thing is, Sorry, I was going to say the other thing was that if you look at the reference diameter for OCT, it's around the diameter of the vessel is around 3.5-ish, and we went with a 3.5 NC 1-to-1 with the vessel, and we had a nice balloon dilatation.
I think you're ready for a start.
Carlo, you want to say something?
Yeah, well, thank you for showing us really the most recent update in the software of OCT that is shown with artificial intelligence able to catch automatically arc of calcium, thickness of calcium, and of course, as my colleague here pointed out, there is very little calcium that the rotational atherectomy eliminates. Just modifies it, creating cracks. And I think we have seen enough cracks to be confident that the stent will be delivered properly. And we saw the balloon expanding well. So the other information is length of the segment to cover, the proximal and distal reference size. I think you have everything to decide. And the question is whether you will go for 2 stents, starting with a smaller one distal, or you go for a 48-3.0, and then you post-expand proximally, relying on the ability of these devices to respond to post-dilatation without losing their mechanical properties. But I think it's an excellent demonstration that OCT automatically gives you the answer, and I think there is an advantage with the intravascular ultrasound in this view.
Carlo, in the OCT that they showed,
35,
was there
48, yes, go
anything
ahead.
to make you go and use IVL, or that was enough?
I will not use in this particular case. I think that we have cracked enough the plaque and we have a sufficiently good response to expect a good result. You have co-registration, so you know exactly where to start with your stent, where to finish. Just go with it and post-dilate aggressively, but we don't need the 40 atmospheres after having used rotational atherectomy.
Perfect.
So you will not dilate first, you will go with the stent.
He's already done the pre-dilatation.
So, we, as Dr. Mari said, we already did the pre-dilatation with a 3.5 at 20 atmosphere, and we had a good expansion. So now we advanced a Zions Sky Point, the 48, yes, please. 48, which is good that we have a 48 millimeter long stent. So, maybe first.
So we have a comment or question from the audience?
No, I have just a comment because I think that it could be interesting for the audience to clarify use of imaging in calcified lesion. I mean, basically, we have 2 different scenarios in calcified lesion. The first one is that at the beginning, we are able to advance the imaging, I mean, IVUS or OCT as well, before treating the lesion. This is one of the most useful aspects of the imaging in calcified lesion, because imaging guides us in the choice of the right device using the score that you show. So the score are useful before in the choice of the right device. I mean, rotablation, ablation technique, or balloon-based technique. Once you are not able to advance the imaging, like in this case, it was not possible because it was a tight lesion, you decided to start up front with the rotablation technique. That's it, maybe the only one option. Then, when you do imaging, it's just to verify the effectiveness of your plaque debulking or lesion preparation. So it doesn't matter the length of the thickness. You have just to check if you were able to achieve cracks, because the final aim of our plaque debulking is to increase the compliance of the vessels. And you are able to increase the compliance of the vessels if you achieve cracks. That's all, just comment.
Great, thank you. Abdullah, you want to say, Carlo, you want to say?
No, I think I completely agree with what the colleague said. The most important is to do before treatment, and what you can do is use gentle pre-dilatation if the device doesn't cross 152 balloon. It will not prevent you from doing rotational atherectomy if needed. The only point I slightly disagree is at the end. It's true that cracks after balloon and after rotational or orbital atherectomy are needed. Possibly after IVL, cracks are so small that you don't see, but still the calcium dilates and expands. We have evidence from the OCT sub-study from Disrupt, almost 300 patients studied, that the one without cracks expanded as well as the one with cracks. That obviously means that the cracks are there anyway.
Abdullah, you want to say something?
No, I'm good.
So as you can see, we are deploying the 3548 SkyPoint Zion stent at 14 atmosphere now. We're gonna do it for about 40 seconds. We usually do, 1 ml per second, or like, depending on the length of the stent, we go the second. This is just roughly. And most likely we're gonna do NC here just to make sure we have a good expansion. This will be followed by an OCT.
Yeah, so the bench testing showed that if you go every 1 millimeter for every second of balloon dilatation, you get a better expansion. So that's why we do this routinely. Now we've deployed the stent.
Fahad, does his blood pressure drop during balloon inflations or stent?
It was not. It was rock solid here.
Yeah, the impeller is doing his job very nicely.
So the blood pressure we have, I don't know if you see the monitor, it's 127 over about 80 or something. The map is 80, something like this. So he's rock solid stable for me.
We're going to go back with the 3.5NC, just post it nicely, and then we'll do the OCT again and see the result.
Continue on or?
Sometimes, Dr. Zebedi, I call it for a poor cath lab staff who doesn't have imaging, if you take an orthogonal views of your working views, you will discover that there are something left behind, because this is two-dimensions view. Sometimes you miss really information which can be clearly seen in orthogonal. You will see some eccentric lesions but not seen here. That's why it may not help you. But if you have IVUS, can tell you really.
16.
20.
We can share.
This is NC, like do.
This is 3.5 NC, doing again post-dilatation at 22 atmosphere.
What about the rest of the LED? You'll do drug-eluting balloon, or you'll just leave it? What's your plan for the rest of the LED? Because
I think we'll take an imaging, we'll just take a picture and then decide. Sometimes with those patients, less is more. We know this patient had, STEMI and end-STEMI. CF low, RCA is depending on the LAD. So if we have a good flow with TIMI-3 flow, we're not asking for perfectionism here. So if the vessel is fine and patent, we may just leave it. If we have dissection, we have to stent, obviously. So we'll take a picture and decide.
Wise move, Fahad. Less is more. Yeah, leave well alone. لا تتحرش بالشريان. The Arabic version. What NC balloons are you using?
That's a 3.5,
Regular.
15 NC at 22 atmosphere.
OCT next.
Yeah, we're going to do OCT next.
And I guess you stayed away from you stayed away from the LED ostium.
That's correct, Mr.
Sorry?
That's correct. We
Okay.
kind of just few millimeter before the ostium.
yeah, it seems that you had a landing zone because there was some part of the LED healthy, just the ostium. Yeah.
So we're going to do the OCT now, post-stenting, look at the result. This will also give us information proximally, distally, how does it look, there's no edge dissection, everything looks nice. That's the beauty of imaging.
Ali, your voice, your sound is extremely muffled. For whatever you want to say it to Fahad, and he will say it to us.
Sorry.
It's very muffled. You see, Ali, during COVID, he fell in love with this mask. And even with him,
Well,
we can't.
you know, he belongs to a family of physicians, and you know, son, they are sponsoring some of the N95, so all of them they are wearing N95. It's been short of the entire world except in Al Sulaimi family. They have supply for N95.
I adjusted my microphone. Do you hear me better now?
Not really, but that's okay.
Not really?
Let's see what this LED looks like.
It adds to the mystery of the case.
Professor Zubayd will just, Dr. Zubayd,
Yes.
we'll just share some slides about the MLD Max.
Sure.
So while the guy's doing the second OCT run, we'll just share some slides about the OCT and the MLD Max workflow. This is published from the Light Lab Initiative Investigator. They basically conducted a study where they did OCT systematically pre and post PCI. Pre-PCI, looking at morphology, length, and diameter, as the gentleman pointed out, that it's basically, we should do the imaging before the PCI, before angioplasty or before anything, so we can decide on the morphology, length, diameter, and we can decide also if we need to do calcium modification. But if you cannot pass the imaging catheter, then you're going to go up front with calcium modification. Then post-PCI, you're going to do, you assess it again for dissections, apposition, and expansion. And it's been shown that doing that systematically will change your decision in 88% of lesions. That's a cumulative effect in terms of length, type, another stent, post-dilatation, diameter, and so on. So what is the MLD Max? MLD is a pre-stenting. When you look at the morphology, you're looking for the features suggestive of high calcium burden, the one we talked about. Length, selecting a healthy landing zone, pre and post. And diameter, picking the right diameter for your balloons, pre-dilatation, if you want to pre-dilate 1-to-1, and picking up the right stent size. Post-PCI, max, you're looking for dissection, if you need to cover the distal edge with a stent. Looking for apposition and expansion. So malapposition in OCT is defined if you have a malapposition more than 3 millimeter, more than 0.3 millimeter from the wall. So length is 3 millimeter and more than 0.3 millimeter from the wall. And expansion, more than 90% expansion related to the distal vessel diameter is optimal.
Great, thanks. Fahad, Ali, you have 5 more minutes, I'm being told.
Yeah, we're ready to do the final OCT.
Sure.
Can you give us another view to the LED, maybe a cranial
You
one?
want to take another view? Sure, yeah.
Go epicranial, please.
Epicranial.
Maybe there were very precious ones. Yeah, that's good job.
Okay.
Perfect.
Okay, that looks nice to me. I don't know what my colleagues think. The stented segment.
Yeah, it looks fine. Looks good.
And it's a long, looks like wraparound LED. It's a very long LED.
Okay, so go to the OCT, please. Oh, we are there, okay. So we're going from distal again, going proximally. So this is like a disease segment that we saw previously, and this is the stent. Do you hear me well?
Yes, we hear you.
Okay, okay, good. So here's the stent, the distal edge of the stent. Looks okay here. There's maybe a very small edge dissection we can see here. So I'm gonna move proximally, see how the stent is expanded. And the software can tell us this. It's actually telling me 137%. So that's quite amazing. I don't know if I believe it, but. So I'm moving more proximally slowly. Overall looks good.
Looks well opposed so far.
Yes. So here we're moving towards the mid segment. Looks good so far. Telling me 180% expansion. So again, we're moving towards the proximal. Looks nice.
It is excellently
This is
opposed.
the-
What do you think?
Yes.
Dr. Adil is very happy with the opposition. Carlo?
Yeah.
No,
So this
it's
is
an
the
excellent expansion.
so-
Of course, it's never perfectly circular because it's unavoidable the presence of some areas where the calcium doesn't fully expand. However, definitely there is a big lumen we saw in the proximal segment in excess of 10 millimeters square, well matching the distal reference. In fact, more than 100% expansion. I think is a very well done job.
Okay,
Because Jassim, you had some concerns early on?
No, it's an excellent result, but what I like post-stenting OCT is you can see the black shadow through the walls of the artery along the stent, which tells you it's a perfect result, really. Well done.
This is the final picture, just another angiographic view. And we're very happy with the OCT results, as you guys mentioned. Very nice result, very nicely expanded stent. I think we have a nice result for the patient. Good.
So do you guys want to fix the circ now?
we will
Yes.
fix it offline, of course.
Okay.
And then again, just one point, you can see there's like 2 or 3 millimeter from the ostium. So we did not go into the left main, which is good.
What's your short and left and short and long-term plan? CIRC, RCA, any?
We're going to fix the CIRC now, so that will be fixed. The RCA, well, I think we'll leave it for symptom-guided therapy. So if we will follow him in the outpatient in the next few months, optimize his medical therapy, and if he's doing well, then we'll just keep him on medical therapy. If he's still symptomatic, then we'll consider the RCA CTO procedure.
Perfect.
You will remove the impella now?
Once we fix the CIRC, if he's hemodynamically remains stable, then we can remove the impella, yes.
So we can see the blood pressure, I'm not sure if you see it, it's 139 over 100 now. So he's doing pretty well.
Yeah.
Great. And one last note, I think this is probably for the panelists and the audience. You know, this kind of procedure is being done in Mubarak Alkabeer Hospital with the volume that you've seen. And,
I have the slides.
yes, and with the volume that you've seen, and without in-house or on-site cardiac surgery. So we started the cath lab 3 years ago, and we didn't have surgery. We still don't have surgery. We're doing about 500 something primaries a year, and 1,200 or 1,300 PCIs with Impella, ECMO, VA ECMO. So I just wanted to hear from the panelists and the audience what you think of that.
You don't have surgical backup, but you have good operators.
Sorry?
Thank you.
You have a good operators, that's more.
Yes, definitely. Excellent operators, but there's no...
The situation will be different if they're structural, because in structural...
So we're not doing structural.
Yeah.
Our colleagues Abdullah and Ali do structural. in a close-by hospital. But as of now, all kind of complex PCI goes on. Yes, Doctor.
Finished?
You're done? Perfect. Great.
Thank you, everybody.
Ali, Fahad, thank you very much. Everybody here in the audience is happy. The panelists are extremely happy with your procedure. We'd like to congratulate you on this really nice case, and thank you for you and the entire team, the radiographers, the nurses, the anesthetists. Our anesthesia department are an amazing department, and they're there on the spot whenever you need them, and they've joined us for this case, of course, so we'd like to remember them and thank them for their great efforts, especially when we don't have in-house surgery. They're not surgeons, but so far, thank God, we've done extremely well in this setup. So thank you very much, Ali. Fahad, you want to say anything for any final words? Best, thumbs up. That summarizes it all. Thank you very much.
Thank you.
Well done.